So, welcome everyone to Spilling the Tea. It's the last Spilling the Tea of the semester where we speak with Earlham alums to see how life has been going after graduation. So, we're so glad to have you all here. This is a partnership between the Center for Global and Career Education and the Alumni Office, and also today the CGH with the CGH's very own Ahmed Deep. So again, welcome everyone. A few general housekeeping tips. If you are not already registered, please consider registering and creating a profile on our new platform called EC Connect. EC Connect is a unique platform that allows specifically Earlham students and Earlham alums to engage with each other. We heard from students that they wanted to connect with alums, and so there you have it. Here's a platform for you to be able to do that. And also go ahead and drop your name in the chat so that we can keep track of who all is participating and things like that. But thank you all for coming. I think we're going to get started with a moment of silence in typical Earlham fashion.
Okay.
All right, so I will hand it over now to Ahmed. Take it away.
Okay, cool. Thank you so much, Ebony, and thank you so much for you guys being here, and thanks a lot for Jim for being here. Before I wanted to start, I kind of wanted to kind of give an overview of how this session is gonna go over, which typically we're gonna address, and at the same time, like let you guys know of how I'm gonna be facilitating this meeting in general. So what I wanted to start with is to do a little bit of an introduction, allow you guys to introduce yourself, allow definitely James to introduce himself a little bit. And then from there, we're gonna go in and talk about the number one topic nowadays, like COVID-19 response in a state health department. How is that? And what what's different? What do we know? Because now as students, we hear quite a lot of stuff. So let's hear it from someone who actually works there. And at the same time, after that, we're gonna talk about the role of chronic diseases and how pretty much what's the role of an epidemiologist in a state health department, so that we get deeper into what's an epidemiologist, what they do, and all of that. After that, we're gonna talk about more specifically about Jim's journey through Earlham. What did he do? How was Earlham after Earlham and all of that? And then after that, I'm gonna open it for you guys for questions, if you have any questions. But also feel free to always, if there's a burning question that you cannot wait to get an answer for, there's the chat is for that. So just please write in the chat that question, and I will make sure to ask it for Jim during his talk. But if you can hold the question until the end, we have a specific time slot for questions too. So as a little bit of introduction and background information about Jim, I think all of you read this paragraph that was in Handshake too, but I would like to remind everyone a little bit about the amazing work that he's done and he's doing. So Dr. James Peacock is, as we know, an epidemiologist, supervises with the cardiovascular health unit at the Minnesota Department of Health. And so he monitors the state and local trends in cardiovascular disease and stroke and related risk factors, utilizing various public health data. since 2018, he manages like a team of epidemiologists and evaluators that are responsible for evaluating and reporting like the quantitative and qualitative outcomes of like two large centers for disease control and prevention grants, addressing the hypertension and high cholesterol and diabetes. In addition to that, he provide leadership on the department of systems of care for like the heart attack and sudden cardiac arrest in Minnesota. Prior to joining his MDH, he worked for like 5 years as a research associate in the Division of Epidemiology and Community Health in the University of Minnesota School of Public Health. There he coordinated like a large NIH funded research study in the cardiovascular health. So there's a lot of cardiovascular stuff, which is very interesting to me, and they hope for you too, guys. And he's also trained in like cardiovascular disease and genetic epidemiology. He holds both a PhD and an MPH degree in epidemiology from the University of Minnesota. And of course, he's an Earlham alumni. He actually had a bachelor's degree in biology and German from like our college that we all go about it. So welcome, Jim here. I think I asked Jim before and he was like, I'm fine with calling me James. We don't want to, we're going to have it the Earlham way. So we're really happy to have you here. And I think it would be really nice to give you a little bit of time to also like introduce yourself to the students a little bit. And after that, maybe I can allow the students also to introduce themselves to you so that you can know a little bit more about the students in here.
Sure. Well, thanks very much, Ahmed. I'm a little embarrassed by that long introduction because that's sort of my standard bio sketch that we get when we apply for a grant or I do a talk somewhere for a professional audience. Yeah, I'm an Earlham graduate from 1995. I actually grew up in Richmond and I'm a Richmond High School graduate from 1991. And interestingly, even though I wasn't raised Quaker, my father came from a long Quaker family and they were among the first folks to settle in Eastern Indiana and Western Ohio more than 200 years ago. So there's a lot of connection to the Earlham area. In addition to my work, I'm an avid ceramics collector. I'm actually the current president of the Minnesota Art Pottery Association, which is just a club where adults get together and show and tell, which is super fun. And I'm kind of late in life coming to running. I actually ran my first half marathon at age 43 and I finished in 2 hours. So I accomplished a major goal there. So yeah, that's a little about me.
Cool. Thank you so much. I don't know if Ima and Midrin would if you guys would like to introduce yourself a little bit, like your name, which class year you are, and your intended majors and minor. And if you have a specialty that you're interested in, you could also mention that.
Yeah, I can go. My name is Ima. I'm actually from Minneapolis, Minnesota. So
hi, Ima.
And I'm studying human development and social relations and minoring in public health. And I'm a junior.
Awesome. Yeah, I'm in the Nokomis neighborhood right now. So Lake Nokomis is about a 5-minute walk.
That's awesome. Yeah, I live in Powderhorn. I don't know if you're.
Oh, great. Nice.
I am Madrine. I'm a freshman. I intend to major in biochemistry and a minor in public health. I'm considering public health as a career in the future. So that's why I really wanted to be here today. And one of the areas that I find really interesting is epidemiology. And I'm so sorry, my camera is off because I'm at work.
It's okay.
So I'm using my phone. So that's it.
Great. Nice to have you here, Madrine.
Cool. Thank you guys for being here. So to dive in the first topic of our agenda, it's basically the COVID-19 response in the state health departments. And as a reminder, you can always guys ask us a question. If any burning question happens, you can feel free to put it in the chat and I will ask it for Jim. But actually, we all know, nowadays, COVID is pretty much, I think, in my opinion, the one word, if it's if we consider it as a word, it's being used in a everyday basis from everyone. And we always hear quite a lot of news. We hear a lot of stuff coming from different places, treat with it differently. And I think having someone with us from the state health department that actually help us a lot to actually get a little bit of different perspective of how all of the stuff are being done there. So I think, James, I want to ask you about like, if you could please tell us like more about like how is the COVID-19 response in the state health department that you're working at?
Yeah, so I mean, like any agency, we've got a defined structure. Folks have roles in sort of regulating certain parts of health delivery in the state. People have regular roles in running laboratories in order to test samples that come in. COVID-19 disrupted everybody's role in the entire state health department, so much so that virtually everyone, all of our 800 and so employees, have been reassigned to support the COVID response. Even if you're not trained in infectious disease, if you weren't trained in case investigation, they moved you into those roles. So we're operating under an incident command structure where we set up an entirely new organizational structure for the entire agency and put people in with different skill sets into various roles. And there's a lot of things that have been happening since really mid-March of 2020 for us. You know, the state legislature and the governor put together different funding packages to support different consulting groups to come in and support some of these activities. We, in addition to the reassignments that are occurring within the Department of Health, we have people from different state agencies coming in to do support. Like I know people that are from the Department of Transportation, people from the Pollution Control Agency, people from our Department of Human Services, which provides direct services to people across the state, filling in certain roles that had to be stood up in a really rapid fashion for the pandemic response. Early on, our state public health lab was the only laboratory in the state that could analyze a COVID specimen. We worked really hard to get good buy-in from the two biggest labs in our state, the University of Minnesota and the Mayo Clinic, to get the capacity up at those institutions to take the burden off of us to be the only ones that were able to test these samples for COVID. Other types of things that have been going on since the beginning. We've had a case investigation process. So anybody that has a positive test gets a call from someone from the state health department. We ask questions about their potential exposures, if it's a known exposure, what types of symptoms they're experiencing, give them some advice about how long they need to be in quarantine, how they can separate themselves from others, when they need to seek a higher level of care, or if they can just manage their symptoms at home. I was early on involved in something called healthcare worker monitoring. So the very early part of that pandemic, and especially as we saw what was going on in places like Italy and on the East Coast of the United States, was there was this very deep penetration of COVID within long-term care facilities. So folks that were in nursing homes or assisted living, and the staff that supported all of those individuals, there were extreme shortages of personal protective equipment. So what we did was when I found out someone who worked in one of these facilities as a nursing assistant, or even as someone as a food service worker in a facility where they may have been exposed to someone, is we would call them up and we would do a risk assessment over the phone with them. We would determine if it was a high, medium, or low risk. We would determine whether they need to go into quarantine. And we would sign them up for something called symptom monitoring, where we would follow them for 14 days post that exposure to find out, did they start to experience symptoms? At what time was that? What symptoms were they experiencing in particular? Did they seek a COVID test after all? And was it positive or not? That's really helped us better understand how the pandemic and how the disease is transmitted within healthcare settings. We've provided, as a state agency, guidance for all sorts of different sectors across the state. So things like long-term care, which I just talked about, work sites of all kinds, schools, our correctional institutions, our unhoused or homeless communities, youth sports, dining, and gyms are some of the main areas we've provided some guidance. We set up, as part of our structure, something called the Cultural, Faith, Communities, and Disabilities Branch, where we issued grants to trusted community organizations to provide really targeted communications and to serve as liaisons with communities who are often disenfranchised. So we have communities set up for organizations like our Somali and our Hmong immigrant communities, new immigrant or refugee communities in general, folks that are Muslim, our LGBTQ community, and our disability community are just some examples. We as a state stood up mass vaccination sites around the state, especially targeting some of these communities that may be experiencing challenges to access vaccination. We're in the process of standing up something called our long-term surveillance annex, that's going to be a process where we're going to be doing some investigation of people that are experiencing long hauler COVID symptoms. So these things that we hear about in the news, people experiencing brain fog, or they've never regained that sense of smell. There are other much more serious underlying chronic conditions that have started to appear in individuals, not only those that have been hospitalized because they had a severe COVID episode, but folks that were able to manage their symptoms at home. So we're going to start tracking that here over the next couple of years. I'm also involved in a group in our data and forecasting branch focused on equity-oriented analyses. So we're making sure that we're able to provide data to communities that haven't had a lot of data about them in the past. For example, I mentioned the Hmong and Somali communities here in Minnesota as specific examples, to make sure that we're getting data to them to help them better understand how it is, how we can create policies and guidelines that help support them best. One challenge that we've experienced early on is that, especially in some of our immigrant communities, there tend to be more multi-generational households. So there's many more opportunities for people to be exposed within their own home than if I'm calling up sort of a standard rural Minnesota family of 2 adults and 1 child, and each one of them can live on the separate floor of a house. When you've got 6 people that are living in a 2-bedroom apartment, we have to create some different strategies in order to support them. So those are some of the main things that have happened. There's a lot more. There's some really specific challenges that have arisen that existed before, but really became acutely apparent with COVID. One is, in Minnesota, we may not be as diverse as many states racially and ethnically, but we have some very specific, unique, especially in our Asian and our African populations in Minnesota. We have the largest East African population of any state in the country, especially Somali and Ethiopian. We also have a very large West African community, specifically Liberian. In our Asian community, we have a lot of Southeast Asian immigrants who primarily came to the US as refugees. So it's very different than a highly educated Indian or Chinese immigrant professional. We've got this large Hmong community as well. So making sure that we're able to get data that really specifically speaks to issues that are very specific to those communities has been a real challenge for us, and we're working on increasing that capacity. I think the biggest surprise for us has been how the pandemic response instantly became very politically challenged. Our agency, I'm assuming most state public health agencies, have gone through some simulations of how they would respond to a pandemic. We've been doing this for decades. And we went through one maybe 3 or 4 years ago as well. So we felt ready to respond, but we didn't understand how the response itself would become politicized. So, officials, publicly, going against public health science about wearing a mask or social distancing, or why we would need to have capacity limitations in indoor environments for a respiratory virus, was something that we weren't anticipating. So that's been difficult for us to navigate. I think another thing that's really difficult within a state health department is that you can provide as much advice as possible. The governor ultimately makes the decision. And sometimes governors follow that evidence and that advice, and sometimes they don't. And there's multiple examples of that across the country. There are certain places where I think the evidence and advice from state health departments has really been elevated and celebrated. I think Minnesota, generally speaking, that's been the case. It's been, I think, a more science-based response. Some other places around the country, that's really not been the case, and state health departments have really been pushed aside as part of that response. I think another big challenge is just how to, now that we've got everyone reassigned into these new roles, how do we, as the pandemic has changed, we're into a vaccination place now, how do we bring people back into their regular roles? And how do we unwind that response in a way that we're still able to provide sort of those key core COVID response services, but also be able to reestablish those core components of what the public health department was doing to begin with, around things like chronic disease, newborn screening, cancer screening, all of these other activities that have really had to stop during the pandemic. And I think another piece is the challenges I've talked about here have really pushed the public health workforce into a very low morale place. People that have been working in public health for 30, 40 years cannot describe a time in which there were as many people leaving the profession as there is now. there is, depending on where you are in the country and what that sort of political environment looks like, there are folks that are choosing to leave because they fear for their safety because of this politicization that has occurred. I think that's going to take quite a bit of time to repair, and it's going to, yeah, it's a difficult place to be right now. We're right in the middle of it, so it could go a lot of different directions, but it's been a real challenge.
Yeah, I totally see that, like how the change is being, and it's actually very interesting to see how, because like for myself, honestly, I didn't like notice that like how other states are actually kind of responding to that, but kind of more focused into the Indiana one, and that's like a different approach that
Yeah,
I think it's very different from Indiana. But you kind of like touched a little bit about some of the roles that an epidemiologist does, but being in your role at the state health department, being an epidemiologist like supervisor, could you please like speak more about like what is actually an epidemiologist like, and what's exactly kind of, I know that we talked about your role within COVID, but in a normal year, how, like,
right.
what's your role exactly?
Yeah, so epidemiology is really a method to understand how disease occurs in populations. So if we think about COVID, for example, we know how it is if I have an active COVID infection and I'm sitting in the room with Ahmed and I cough, how that's a potential way he could be exposed and then he could acquire COVID. Epidemiology is more focused on what puts someone at a higher risk of an infection. And what would put someone at a higher risk of, say, for example, someone being hypertensive to have a heart attack later. So we're looking more at the population health as opposed to individuals and individuals' specific health. There's been some really great, I think, elevation of epidemiology as a discipline just in popular culture in the last 20 and 30 years. And there's some great books about really interesting work that occurred early on in the HIV epidemic to really understand HIV transmission, how that leads to AIDS, and the development of treatments for HIV. There's been some really interesting, I think maybe a little bit sensationalized depictions of really searching for some very specific unusual viruses that have moved from animal into human populations. A lot of interesting discussions of how Ebola and Marburg virus and some other sort of diseases that are borne by either ticks or mosquitoes have jumped into populations. So that's a part of epi. That might be a more glamorized sort of version. I think what epidemiologists do, most of us are probably working behind computers. And for chronic disease itself, this really sensationalized and interesting examinations of how we've done infectious disease epidemiology, like I just mentioned, in upper and middle income countries, as we've really come to understand how to control and manage infectious diseases, it's really chronic conditions that are the ones that bear the biggest burden on populations. People are going to die of chronic conditions. People are going to live with chronic conditions for a long time and have to manage them. They can be incredibly expensive. And that's sort of the space that I'm sitting in, is how do we better understand how to prevent and manage chronic conditions that cause strains on families, on communities, on government budgets, and so on. Some examples of types of epi that have supported the understanding how it is chronic conditions happen is, being able to link smoking to lung cancer and heart disease, which took many decades and really to prove that link. But that's epidemiologic work that was done in order to make that connection. Most of the work that I do in chronic disease space is not identifying new links. It's better understanding sort of the distribution of risk factors that exist within Minnesota, which communities might be more impacted by some of those risk factors, how those risk factors might align with resources that would help them either be screened to identify that risk factor or to effectively manage that risk factor, and use that information in order to determine where it is we might prioritize the very limited dollars we have in order to improve health in the state. most states in the country dedicate no money to support chronic disease research, prevention activities, anything of that sort. Minnesota is somewhat unique. We're one of the few, and I believe we were one of the first to institute a public health partnership through our state public health department and then local health departments and the tribal governments that exist within our state for something called the Statewide Health Improvement Partnership. It started in 2008. It was part of a large healthcare reform package that was pushed through our state legislature and signed by our governor at that time. And it's specifically asking for local public health agencies to work on arguably the two biggest causes of chronic disease burden. So that's obesity and tobacco use. And on obesity, they're really focusing on making sure that people have good and equal access to healthy food options. It's not all processed food that's available. And also increasing opportunities for physical activity, which is especially important in urban communities, in lower income parts of urban communities, but also very important in Minnesota's many rural communities where there is no rec center at all for 50 miles in every direction, or there isn't even a crosswalk at the one stoplight in town, making it dangerous for people to be out as pedestrians in the community. My role itself, I've got two major roles, as Ahmed mentioned in the introduction. It's really focused on the epidemiology and the evaluation piece. And that's one component. I've got another component, which is in the program work. And so, Nadreen, I'm really glad you mentioned epidemiology being of interest to you as someone who's interested in public health, because although I'm trained as an epidemiologist, I really think of myself as a public health professional first. Where I'm doing things that are broader than just analyzing data, looking at risk factors, but trying to come up with solutions for how it is we reach communities in need. How do we effectively implement a policy? How do we introduce a policy and get public support behind it when we know that that is something that could improve the overall health of the community? Those are sort of within the scope of what I do as well. So there's that epi and evaluation place where I'm helping to better understand how we measure health status in those communities. How are we making progress on the implementation of the programs that we're doing? And then there's this other side, which is more the program work. So for example, one of the things that's in my portfolio right now is leading strategies to expand pharmacists as providers of services that help people both identify that they've got chronic conditions, but also to help them manage better. And it's not just by prescribing the medications, but it's by doing lifestyle counseling with them when they come up to the window, asking questions about, is this medication working for you or not? And then listening to that person and figuring out, do we need to make a change to the dosage or the timing? Or is this medication really not working for them at all? Do I need to get a call back to that physician and say, I don't think this is getting the person to the goal that they're looking to get to? He mentioned also in the introduction here that I'm leading something called heart attack systems of care work. So a heart attack is something that if you're experiencing chest pain, you need to seek care right away, because every minute that you wait is causing more and more damage to your heart, putting you more at risk of death. Minnesota is a state, while we have a very large urban community in the Twin Cities, we've got expanses of rural communities across the state where people are really far away from definitive care services. So part of creating a system of care around heart attack is making sure that people understand the signs and symptoms, that they call 911 as soon as they recognize those. And then when 911 is called, that the EMS service, the emergency medical service that would come to pick them up, knows exactly what to do. They've got a protocol in place to triage that person and then make a determination. Do we drive them 10 miles down to the small 15-bed hospital? Or do we need to drive them 2 hours to Minneapolis or to Duluth or to Rochester, where they've got the highest level of possible care for that patient? That's a really critical thing, especially in parts of the United States, but I think really across the world, where there's differential levels of access to care. So that's something that we also do in state health departments. I help lead the chronic disease division in a couple of areas here. One is I, along with a partner of mine, we've really become I think, the leading experts on understanding how you use claims databases. So in the, every medical service in the United States, a claim is filed for that service through the insurance company, and they either pay it or they deny it. A claim is also submitted for any medication that's distributed through a pharmacy claim. So we have that data from everybody receiving medical services in the state of Minnesota, and we're able to get a really good sense of where are certain services happening and where are they not happening in the state that can help us identify this community of people doesn't have equal access to cardiac rehab. How it is that we build up capacity in the healthcare system in order to provide that for the first time to people? Or do we need to create policies that create alternative ways of delivering the cardiac rehab service? For example, instead of doing it in person, maybe we do it virtually through a Zoom call, something like that. Looking at these sorts of pieces of data can really help us make determinations about where there are gaps and how it is that we can creatively try to fill those gaps in a way that's really beneficial to the patients out there in the community, but also to the payers and the providers who would be both paying for and leading and providing that service to those patients. Another area where I've become a bit of a leader is figuring out how we use geographic information systems and mapping techniques in order to evaluate the work that we're doing. Are we reaching the communities we say we're trying to reach? Can we identify communities where they don't have access to services? And then how we can also use mapping information to communicate messages to the public to encourage using services that are out there that are available to you. And then finally, I'm also serving as a lead for a new group that we've put together where, cardiovascular health unit, we're fairly large at the state. I mean, it's the #1 killer, so it makes sense that we're a larger unit. But we also have, for example, an oral health unit, and we have an asthma unit, which, each of those has 3 people. Within those 3 people, they don't have all the skills they need in order to effectively evaluate their work, to engage the community in what's needed, to do surveillance work like an epidemiologist would do for them. So I'm leading a team that can provide some sort of consulting services to meet needs for those other groups as well.
That's really cool. That's a lot that an epidemiologist does. I think whenever I thought of it, I thought it's gonna be focused only on data and stuff like that, but there's much more things that an epidemiologist can actually do. So thank you for actually clearing that up for me, at least. I didn't know for you guys too. Yeah. I think moving to the next one, which is I think what students are most, and myself almost really excited about or wanted to learn more about is how does EC fit in all of this? We're all at the undergrad level. We have freshmen with us. I'm a sophomore. Currently, Ema is also a junior. So we would like to kind of learn more about your trajectory from pretty much from starting from EC to going to where you are now. If you could maybe touch a little bit on the classes, the major that you said, and I know I mentioned a little bit, but also talk about maybe how did EC prepare you for what what's coming after?
Yeah. So as Ahmed said at the beginning, I was a biology major. It took me about 15 minutes, I think, entering college to decide that I was going to be a bio major. I think I knew as I entered, but I wanted to check out politics as well. Yeah, so I was a bio major. I don't recall if in the early 90s we had a formalized biochemistry program. I don't think we did. There might have been a concentration at that point. But I was going to follow what was sort of a rough pre-medical track at that point. And I wanted to supplement that with some other bio courses. So for example, my favorite biology course of all time and will remain for all time was ornithology, which says nothing about my my epidemiology career, but I do love going out into the woods and looking for birds still to this day. German is my second major, and that sort of happened by accident. Part of the reason going to Earlham was I really wanted to take advantage of the off-campus study opportunities that existed there. And the Germany-Austria program was one of the 2 or 3 that was really high on my list. It fit best with my scheduling. And so I went on that in the summer between my junior and senior year, and then was there also in the fall of the senior year. When I returned, I only needed 2 additional courses to complete a German major. So I can't remember what the one course was that was available, but in order to get to the major, I had to design my own course, which was a translating course, and it was focused on translating medical and biochemical and genetics scientific abstracts from German into English. So I may have set that up in a way that made it easy for me to pass, because Margaret Hampton, who was my professor at the time, and I think just retired, she didn't understand the technicalities of some of the words, so it probably worked in my favor. I considered doing a pre-med tac. I also knew that I wasn't a person that did very well with blood, and I didn't do very well in some of the dissection work in the anatomy and physiology course. So I thought I need to do something in that medical space, health space, that's not going to be direct patient care. I think what Earlham also prepared me for, independent of the coursework, was because it's a liberal arts college, because they really want you to get this broad experience across many, many disciplines, that fits so well with public health as a discipline, which is incredibly interdisciplinary. Yes, an epidemiologist is sort of medically, statistically focused, but as I described, I'm also a public health professional. I need to be able to understand how to effectively engage with communities that look very different than I do. I need to be able to understand how to work with providers that are providing direct medical services to folks that have a very specific mission. A physician's got a very narrow, deep knowledge. I feel like public health needs to have a broad set of knowledge that can also talk effectively with people who are real experts in these certain narrow silos. I think that a liberal arts education like at Earlham really sets you up to do that well. My friends from high school who went on to big state universities or big private universities like the University of Notre Dame, when they would enter a program, I felt like they were being much more prepared for a specific career or job than they were to learn broadly about a subject. And public health is a place, again, where you have to be ready to learn as new information comes in all the time. It's not that we were making up as we went along here with COVID, but COVID really threw a lot of different surprises at us, and we had to be able to pivot rapidly. And being really technically trained in one sort of silo, those were folks that was difficult for them to be able to pivot quickly. How did I get to where I am now? I mean, I graduated in 1995. I wasn't quite sure what I was going to do. I didn't have graduate school specifically on my mind at that point, but I actually did reach out to the alumni office and I made a connection there. And it turns out the guy that I got connected to, he was an Earlham graduate from 1939. And he also had graduated from Richmond High School, just like I had in 1935. And he had been running a program at the University of Chicago's medical school since the early 1950s. And it was an autopsy study where they, starting in the late 60s, where around the country, they looked at young people between the ages of 15 and 35 who had died of accidents. And they did this autopsy study, and they were able to demonstrate that even in these really healthy people with no evidence of any disease, that they already had clogged arteries. So it was one of those really early studies that was establishing that high cholesterol, atherosclerotic disease building up and constricting those arteries around your heart was a progressive disease that lasted over decades, and that people are walking around with it all the time, and we don't know about it until they have a heart attack or they're experiencing chest pain. So that was kind of exciting. That's actually, he said to me, well, if you want to do this type of work in chronic disease epidemiology, which is essentially what this was, even though he was trained as a medical doctor, you should go to the University of Minnesota. My best friend, who I play tennis with in Florida each winter, he works there. So that's kind of what pushed me up to Minnesota, and it being a really good fit for me. When I came to Minnesota, the idea often is, if you're going to go to a PhD program, is that most of the time you're being trained for an academic career. So to teach and to do research at another institution. And as I went further and further along through the program, I found that just wasn't going to work very well for me. And while I really, I appreciate the folks that can work 80 hours a week in order to get to tenure, I knew that I needed to have more separation between my work and my personal life. And most of the work that I was doing, within that sort of academic epidemiology setting, were working on things like case control studies, or primarily long-term cohort studies or observational studies, where you bring people in for a bunch of lab tests and you follow them for 15 to 20 years to see if they develop disease. It's great evidence for that physiologic process of how a risk factor leads to disease. It's not very, to me, it felt very detached from people. And when I would write papers, I was verifying evidence that was already out there, strengthening it. But it takes a long time for that type of work to go into clinical practice or to become part of a policy. And I didn't get as much fulfillment out of that as moving over to the state health department, where we were running programs where I get to directly talk to the person that's implementing that program. And sometimes you get to meet the patients that are benefiting from it. So that's what kind of drove me from that academic more into this sort of public service government epi side.
Yeah. That's actually really interesting of how like graduating from EC, meeting an EC alumni, and then moving.
Yeah.
I've heard like so many stories from EC alumni that kind of the same thing, that they got where they are because of the connections that they made here. I want to open it now to the students if they have any questions that like they want to say, any statements that they want to say, stuff that they want to share also. Pretty much feel free to unmute yourself and go ahead and ask questions.
Yeah, it doesn't have to be anything that we've talked about either.
Mm-hmm.
I have a question.
Hi, Madreen. Oh no, it's Ebony. I'm sorry.
Ebony here. How long? That's an interesting fact that you brought up, that you can study something and it, you can strengthen research that's already out there. But how long does it typically take in a regular universe, where COVID is not plaguing all of our lives? How long does it usually take for research to become practice?
I think it really depends, but there's been a change in the way the US federal government has been approaching doing medical research in general, where they're focused more on something called translational research, because there was this observation that, millions and millions of dollars going from the National Institutes of Health to support these projects about heart disease or cancer. Tons of great evidence is coming out of them, but it's difficult to get that evidence converted or translated into medical practice. And the idea of translational research is to more formalize, I'm not going to say this exactly right because I don't live in this space anymore, but my understanding is that it's an effort to try to accelerate that process, to make sure that, yes, it's important that we're funding research for research's sake, but the research needs to also have a purpose and an end in mind. And that end, usually is to improve human health, to reduce the burden of disease, and so on.
That sounds like a lot of what you said and what you just spoke about translating the research, sounds like there is going to be a pretty high demand for liberal arts students, and the fact that Earlham students and other liberal arts students can think like interdiscipline, between disciplines. Science majors are required to take those humanities courses, and they know how to do those things, even though they may not live in that space 24/7.
Yeah, I mean, I can speak very clearly to when we're hiring for new positions, and that could be for something technical like an epidemiologist, but it could also be for a community planner. We'll have 5 or 6 candidates that we interview. The flavors are going to be so different. The passions that these individuals have, and what I'm challenged with sometimes is we find a lot of folks that are very, very technically proficient, but there's not a lot of passion or mission or drive behind. They're not giving us evidence of that. And where I'm going to see someone that's going to be really successful in a role in a state health department is someone that's really passionately driven, that they're bringing different experiences from their own life to inform how it is they do their work. Not just that they, and I'm going to use some epi speak here, they can run a rate ratio effectively. We need people like that, but in a state health department where you really are under-resourced, you need people to be able to fill multiple roles. We need people that have that kind of broad view, I think, to be really effective leaders and members of the team.
So I guess my next question is, do you need interns?
We often are looking for folks to do certain roles. I will say that the pandemic has made that really hard for us because we're, as a government agency, under a lot of constraints about how does we do hiring, for example. It can be a long process to get one of those in place. What I've tried to do prior to the pandemic was try to make sure that I talk with a couple of my other EPI colleagues over the course of a year. We maybe meet every 6 months or so and say, hey, here's some projects we'd like to get done, but they're always on the back burner because we don't have time to do them, or because they don't directly fit within the expectations of this grant funding that we have that has deliverables 1 through 10. This is item number 12, doesn't really fit under that, is to update those, make sure those are ready to go. And we frequently, because we are in Minneapolis, or in St. Paul, Minneapolis, right next door, the University of Minnesota has a School of Public Health. We're often hearing from faculty members over there about students who need to do a field experience in order to meet their master's degree requirements. We do have sort of a sister college to Earlham is Macalester College, based here in St. Paul. They actually have a public health program as well. And actually one of our most recent hires is an evaluator who went to Macalester. She's great. I think it's because she brings some of that sort of diverse experience, this liberal arts approach to how does she works with communities and does her work. We've started doing some internships with folks from Macalester who are at the baccalaureate level. So, yep, that's something we look for. Long answer to that short question, probably.
I mean, I think that's really cool to always I think get that information to students, especially Earlham students. I don't want to brag about Earlham students, but I think we're really, I think, something that really distinguish. I can speak from what I see. I'm a pre-health peer mentor now, and that's something that I see the passion in the students, that they're like really, really passionate about that. So I don't know, I am more than happy whenever there's an opening at your institutions to pass that information to all of my mentees and other students that are actually willing, because also something else that we do have nowadays, I don't know if you're familiar with that, but we have something that's like the EPIC Advantage. And this is basically an opportunity that Earlham, like, is one extra thing that Earlham gives for their students. It gives them like the financial fund to actually go and explore one spaces. So some of the students, if they're willing to use that like chance, they can use it. And it's like every single student, once they get admitted to Earlham and they become an Earlhamite, then they do have that opportunity. So it's for each single student. So yeah, I think it's something really good to know that like some opportunities like these to happen.
Yeah, I would say sometimes we get a lot of requests for positions. Sometimes we often try to make sure that we're especially fulfilling the needs for someone that may need it for like a degree requirement or something like that. Mm-hmm. But this actually think would sort of fit within that sort of theme as well. Yeah. So yeah.
I don't know if the students have any other questions.
Yeah, I was curious because I am interested in public health, but I'm coming from more of like a social sciences background. Mm-hmm. And so I was wondering how many of your colleagues come from that background versus like biology and stuff like that.
Yeah, I'd say it's a fairly high percentage. Actually, my lead evaluator on my team, I believe she has a sociology degree. She worked prior to us in a variety of places. She worked with a nonprofit called the Center for Victims of Torture. Did a couple of years working in Uganda. She worked with another sort of contract research organization here in the Twin Cities that does a lot of sort of multicultural and intercultural contracts on evaluation called Rainbow Research. Another way that we often can kind of determine as folks that are doing analysis, it's which statistical software package you're most familiar doing your analysis in. SPSS, if anyone's using SPSS, we know they're from a sociology background. And we've got a few of those for sure. Yeah, I think sociology is a great entree into public health because it's also a way to kind of remind folks that it's not just the medical model of how we think about disease that influences public health. And that's something that I think as a discipline we need to be reminded of, especially within state health departments, where there might be a little bit of preference for folks that have more of a biology kind of medical doctor sort of a viewpoint. So I would highly encourage that.
I would actually like comment a little bit on that. I'm like minoring in psychology and public health, and I think I do see a huge connection between also psychology and public health and how they're kind of really interrelated in so many stuff. Like many of the psychology, I think many of the requirements for the public health minor kind of overlap a lot with the psychology like major or minor at the same time. That's how I can do both at the same time. But it's generally, I think, especially with the liberal arts and how Earlham kind of designed the courses, I think it's like sometimes some courses are really flexible that they can count for different stuff. So I do think also I'm not sure if like psychology was a big major before, especially like I think now that has a lot of attention towards psychology. But I do learn a lot about public health through psychology. So I think it's really, really interesting too.
Yeah, that makes a lot of sense to me. And so it's exciting for me to hear that even as a place as small as Earlham, there's this diversity of sort of training programs that exist. And again, the evidence is they overlap a lot. And I think that's important. And that says a lot about what, what a position would look like in the future, is that you're going to be set up for success if you've had many of these different experiences across these multiple disciplines.
Yeah.
Okay.
Madrin?
Oh, okay. Hi.
Hi, Madrin.
Hi. I was wondering, you were talking about those communities that you are trying to collect data from, like people from West Africa or East Africa, these small communities. I was wondering what kind of challenges do you face while you're doing that process? Because I remember in high school, I was doing a lot of public health education, and we could go to these local tribes where it was very hard to just pass that information to make them just be aware about a particular health issues that we're trying to address particularly. I was just wondering what challenges are you facing with that group particularly, and how are you overcoming it as a public health professional?
I think specifically the challenge that I was sort of bringing up earlier is related to being able to report good data back to those communities in a way that's actionable. And I would say the challenge is less about us knowing who the community members are that are being affected by COVID or by heart disease. It's more about understanding how many members of that community actually live here. We don't have good denominator data. And so it's difficult, for example, to calculate a rate to say, how much more impactful is this in the Liberian community compared to the US born African-American community, for example. One challenge I've experienced is that typically speaking, cardiovascular disease in the United States as a whole, it's about 20%, 25% more prevalent in the African-American community than in the white community. And it's often affecting African-Americans at a younger age. But when I look at data in Minnesota, and we do all of our fancy statistics to age adjust these to make sure we're doing fair comparisons of the rates, we see no difference between whites and blacks in Minnesota. Well, a lot of that has to do with the fact that we've got a very unique population here that I described earlier. We've got a lot of very recent immigrants, both from East and West Africa, which on paper are much healthier in general, because many of those risk factors that would convey heart disease on someone, obesity, low physical activity, poor diet, those are not things that have been picked up by these recent immigrant communities yet to the same degree. So in many respects, they have less exposure to these cardiovascular disease risk factors. And having these two communities sort of being viewed as the same by the way our data are collected really masks that there's just as big a problem for US born African Americans in Minnesota for heart disease as there is in the rest of the country. So these are challenges we're faced with a lot. And a lot of it are things that are not in the health department's control. We're not the ones that are out there like the Census Bureau collecting this data that we use for denominators. but we need to come up with some alternative ways to be able to communicate data effectively. One thing that we're trying to do right now is to put together, you may have heard of something called community-based participatory research. It's really where a community that's being studied is engaged from the design of that research project at the very beginning, so that that research is being designed in a way that's respectful and is useful to that community that's being studied. We are looking to try to put together something similar to that, but it's really about some of these smaller communities in Minnesota that are really challenged with understanding their health status, is to engage with them directly about what are the specific questions that you want to address around health status for, let's say, Liberians. And engage them with that, make sure that we, the ones who hold, collect, know the data that's available, can try to find ways to provide something back that is going to be useful and impactful for the Liberian community, even if it's not the same kind of data we could provide if we were just looking at whites versus blacks versus Asians versus Hispanics in the United States, which is the way that we typically classify people by race. Does that help sort of answer the question a little bit? That's just one little piece of what we're trying to do.
Yeah, okay, great. My one last question. I know,
Yeah.
I don't know if it's time up or something, but I heard that there've been a shortage of bioinformatician, especially now with the pandemic and everything that's going on. Is it the same? Is it the same thing that you're experiencing in Minnesota?
I didn't hear the very first part of the question. Could you repeat that?
Sorry, I think I'm far from my laptop. There is a shortage of bioinformaticians, especially after the whole COVID thing happened. I was wondering if it's the same issue in Minnesota, and how do you think that affected how we responded to COVID-19 as a community in general?
I don't know. I don't know that I heard about being a shortage of that kind of a shortage here in our state. I think the big challenges really in terms of the response were just related to initially the fact that there wasn't personal protective equipment available. One thing, and this is a bit of a political response too, is there's been this lingering emphasis on disinfecting everything that anybody could potentially touch, when we know clearly that this is a respiratory virus, that it's being almost exclusively, people are contracting it by breathing in air from someone close to them that's infected. That kind of information, I think we should have really focused on the respiratory component earlier.
Oh. Okay, great, thank you.
Sure.
Cool. Yeah, I think if you guys don't have any other questions, I do have one question for you, James. Or Jim, sorry for being so formal.
That's okay.
I'm wondering, like, what's one advice that you would like to tell the students?
Yeah, I think really take advantage of resources that are around you to make personal connections with people. So, my path really started with talking to the alumni office and being connected with an Earlham alum who was really passionate in an area that I was also very interested in. He took a chance on me, and I'm so grateful for that, having been able to move from Richmond to Chicago and then on to Minneapolis. And 25 years later, this is where I am. I think that's probably really the key thing. When you're reaching out to people though, and one thing I was going to do is I'm going to put in the chat here, this is my LinkedIn. I would recommend using LinkedIn. This is a tool that wasn't available to us 25 years ago. And it's really a nice way to be able to become connected to people that are real experts and influencers in their field that are doing really interesting things. Every job that we have at the Minnesota Department of Health, we advertise through LinkedIn. So if it's something that's like connected to me, someone I would be working with, I often promote it through those channels as well. If you're going to approach somebody in the field, to get more experience, I think it's great to ask for some type of an informational interview, but I wouldn't approach them and say, I'm a public health minor. I would like to talk with you about this. I think you need to sort of express a little more, like, is there a particular subject or topic that you're really passionate about? Engage them on that type of a conversation, because we get a lot of requests for folks that are interested in internships and so on. And if all I know is that you need to do an internship in order to meet your master's degree requirement, but I don't have any other information, it's really hard for me to come up with something that's going to be mutually beneficial. So I think, really putting out there, exploring, knowing, sort of a passion in that area, and being able to express that and talk about that with folks that are working in public health or whatever discipline it is, I think is really key to getting a productive conversation going.
Cool. Well, I think I can now head towards like wrapping up this session, but if there's like not any more questions, thank you so much for this advice. Thank you so much for being here with us today. Definitely we have your LinkedIn here, and anyone who, if you guys have more chats, I think I can say that you can reach out to Jim
Absolutely,
more.
for sure.
Yeah, as I'm not sure if you guys like saw the chat, but as Ibn said, if you are like, please go to EC Connect and sign up for an account. I actually made my account 2 weeks ago, and there's really a lot of alumni there. And the very nice thing for that website is actually kind of narrowed down the alumni that you can connect with and stuff. And they kind of post, it's a really nice platform to see what people are doing and what you could like potentially like contribute with, or if you have a question for someone that you want to ask about, that's also always an option. If you need help with that, I'm more than happy to help you signing up for it. But yeah, again, thank you so much for everyone for coming today. I hope that you learned something. I learned a lot of stuff, and definitely thank you so much, Jim, again for being here with us.
And please reach out, as Ahmed said. I'm happy to talk.
I think I will, because that's my area.
Okay. And Ina, you live close, so maybe we'll see each other in the future.
Yeah, definitely. Thank you. Thank you, Ahmed and Ebony, as well.
Yeah.
Thank you.
Have a good day, everyone.
Okay, take care, everybody.
Take care. Bye-bye.